Hey everybody, welcome back. Welcome back to The Doctor's In, live with TOA. I'm Dr. Stahlman. I'm a spine surgeon here with Tennessee Orthopedic Alliance. And it's Friday, which means it's The Doctor is In Day. First off, I wanted to thank everybody who's been watching up to now. I hope these episodes have been interesting. I hope that you feel like you can talk to us about topics you'd like to hear about. They're fun for us to do, so let us know what you think. You can comment below, down there, or you can email us at www.toa.com. Anyway, before we get started, once again, disclaimer here. I am an orthopedic surgeon. I've been with Tennessee Orthopedic Alliance now for almost 25 years. But I'm not your orthopedic surgeon, and this information shouldn't be considered medical advice. Really, we're just talking. Education is the name of the game here. If you have a medical problem, a musculoskeletal problem, and you are concerned about it, why don't you get online at www.toa.com or give us a call and make an appointment with one of our multiple 60 some odd doctors and practitioners now that can help try to make your life better for you, okay? So before we get started with today's topic, I do want to give a shout out to Dr. Mark Kessner. Dr. Kessner is a chiropractor in Murfreesboro, and a couple of episodes ago, I talked about chiropractic and acupuncture and other kind of complementary care tools for back pain, and Dr. Kessner reached out via the comments and gave me some information and invited me to come down and visit with him, which my compatriot Brooke, who's quitting behind the scenes, and I went down and we spent the morning with Dr. Kessner in his office. It was interesting. I learned some things. I actually let him adjust me, and it was we had a good conversation and shared a lot of philosophies with regard to management of back pain and care, and it was a great visit. So I hope he learned something from me. I certainly learned something from him, and I appreciate Dr. Kessner and his staff taking the time to make us feel very welcome. So thank you very much. So today's topic, I thought rather than a specific medical subject, I thought we'd talk a little bit broader about surgery itself. And a lot of people have not ever had surgery. Some people have had a lot of surgery. And I wanted to kind of give you a feel for what happens at surgery, okay? There's a lot of things that happen around surgery that gets to be a little confusing, gets to be a little scary. And I thought I'd just give you a little bit of tidbit information about what goes on and why we do some things so that you have a better understanding if and when you have to undergo surgery and you're not so scared or not so nervous. Now, it's important to understand that there's all sorts of types of surgery. We're going to generalize to surgery on the body, so skeletal surgery, that is under general anesthesia. General anesthesia means that the anesthesiology team puts you to sleep and keeps you asleep while you're having your operation. So this information will certainly apply to any type of spine surgery. It'll also apply to most joint replacement or orthopedic surgeries. It can apply to surgeries that happen when you are admitted to a hospital and stay in a hospital, which is called inpatient care, or it may also be appropriate for outpatient surgery, such as in a surgery center. So I'm going to freeform a little bit, but I thought we'd talk a little bit about kind of from the beginning to the end what happens, okay? So when you and your doctor decide that surgery is the right thing for you, there's kind of a logistical cascade that occurs to try to get things processed and done. So the simple stuff is paperwork. And the paperwork is getting your medical history, it's getting your insurance, it's getting approval from your insurance company for the procedure. The doctor's office provides information to the insurance company. They go through a process, and that can sometimes take a couple of days, even a couple of weeks to get approval. So just because you've decided to have surgery doesn't mean it's going to happen immediately. So that background process has to occur. Once the surgery is approved and you have been scheduled for surgery, so you will get a date and a time of when your surgery is going to happen, a lot of things are asked of you. The first thing, many times people are asked to go to a pre-operative medical clinic, or what used to be called pre-anesthesia testing. And it's basically go to the facility to have an evaluation by a medical doctor or a nurse practitioner or both to see about your health situation. So how are your heart, how's your lungs, other medical conditions, to determine, one, is it safe to undergo anesthesia and surgery? Two, are there things that need to be done to make sure it's safe to undergo anesthesia and and surgery? Or if there's other factors. So they will talk to you, they'll examine you, they may draw your blood. Occasionally, depending on your health situation and where you are in your age group and whatnot, they may request further information, either information from your primary doctor, information from your cardiologist, or they may actually ask you to go see one of these physicians to make sure that we can minimize the risk to you when you undergo surgery. Okay? Anesthesia is medicine to put you to sleep and keep you asleep. Surgery is traumatic and stressful to your body. Both of those things can affect you if you're a little bit medically frail or sickly or have medical problems, and we need to minimize the chance that what we do to you can hurt you. And so a lot of people get frustrated when they're asked to go to the pre-admission testing or pre-operative medical clinic, but it really is important. More so for the anesthesiologist than anybody, but it's really important for the whole team to understand exactly what kind of condition you're in so that we can do as much as we can to decrease the chance of having a complication or a problem. So while it's a hassle, while it takes some time, it's actually very important, okay? So let's get past that now. So you've done your pre-anesthesia testing, you're good to go medically. What's going to happen next is you will be given some information. And the critical information for you will be what time is your surgery, what time to show up for your surgery, and what you should be prepared for, what you bring, etc., for surgery. Now, they'll give you a surgery time. That's usually a pretty good time, however, because surgeries run on a schedule. Sometimes an operation ahead of you may go longer than anticipated, and so your surgery may not start at the exact time that they say your surgery time is. That's just part of life. We have to just take it as it comes. An important time is when they tell you to show up. And almost always, most facilities will tell people to show up about 2 hours ahead of their surgery. Now, that varies depending on the facility and what type of surgery you're having, but that's actually a very important time frame. And the reason why is there's a lot of things that happen between you hitting the door and you going into the operating room. The facility has to fill out some paperwork. They have to have you sign your consent form. They have to identify you and make sure you are who you are. They have to get you prepared, either dressed or showered or things like that for the surgery that you're having. They have to put an IV, which is a catheter that goes into your veins, so they have access to your bloodstream to give you medications. And all of that stuff takes time. So it's really important when somebody is told, come in 2 hours ahead of your surgery, or whatever time that is, that you really listen to that. Because we don't want to delay you because we don't have enough time to get all that stuff done. We don't want to delay people behind you either. So it's really important to listen to those instructions and remember that this is for your safety. This is for your getting through surgery well and without any harm, okay? Keep in mind, particularly around Middle Tennessee and especially Nashville, traffic can be crazy. Weather can be crazy. Accidents happen. So it's always best not to cut it close, but to give yourself extra time in case something occurs that you have no control over. You really need to get there that time frame ahead of your surgery time in order to get all this stuff taken care of. Another instruction that almost every facility will give you is don't have anything to eat or drink after midnight the night before your surgery. So for example, if your surgery is scheduled for 9 in the morning, you don't want to eat or drink anything after midnight. Sometimes they'll tell you it's okay to take certain of your medicines with a sip of water, but you certainly don't want to have a morning cup of coffee or a biscuit before you get in the car to go to the hospital. Why is that? Well, this is another safety thing. When we put you to sleep, when we take over your breathing and your heart rate and things like that with these medications with anesthesia, it is possible for you to vomit. And if you have food in your stomach, if you have liquid in your stomach, you can throw up, and also suck that back down in your lungs. And that can cause serious injury to your lungs, including bad pneumonia and even death, okay? So when they tell you nothing to eat or drink after midnight, for example, listen to them. There's a reason why. I can't tell you the number of people who have not listened. They come to the facility with their bag from Hardee's in hand with their biscuit half eaten, and we've had to cancel their surgery because they didn't listen, okay? So it's a safety thing. It's not because we're trying to be mean or ugly. It's not because we're trying to deny you your morning coffee. It really is an important basic instruction. So that's why we do it. So it's important for you to really understand that and listen. Okay, so you're in the hospital, you got your IV, you've got your name band on your wrist. What happens next? Well, we take you to the operating room, and there's a team of people in the operating room. Now, you've probably all seen video or movies of scenes in the operating room. Oftentimes, if it's an older movie, it's tile walls and bright lights hanging over the bed where you're going to have surgery. Some of that's pretty accurate, but operating rooms look like all different kinds of spaces. Basically, an operating room is just a big room that we have some special equipment and the tools we need to take care of you, to give you anesthesia, and to make sure you do okay, all right? So it doesn't really matter what it looks like. They're all kind of different, but they're all kind of the same. There's usually lots of equipment. It's usually very bright. It's usually very cold. And you'll meet a number of people in the operating room. Now, depending on your surgery, the number of people varies. But in general, the people you will meet in the operating room are the CRNA, who's the nurse anesthetist, who will be taking care of you during your surgery. That person monitors your vital signs. That person keeps you asleep. That person keeps you from feeling anything or feeling pain, keeps you alive, and wakes you back up. That person is generally supervised by a physician called an anesthesiologist. So that's a doctor who is trained to manage anesthesia. It used to be years ago, when I first started, the anesthesiologist was the one sitting at the head of the table doing all the medications and such. That's changed over the years, and the CRNA has really taken that role during the procedure with supervision from the physician anesthesiologist. Another person you'll see in the room, and you may see this person in your holding area room before you go to the operating room, is a nurse called a circulating nurse. So basically, when the doctor is scrubbed in and operating, he or she can't go out and get materials or devices or things that we need. We need somebody who can help us gather materials, gather instruments, and that type of thing that's free to go in and out of the room. And so the circulating nurse is in charge of charting the case, making sure they document what's happening, also going and getting things and being a support person for the surgeon. The circulating nurse is really important to me because, for example, if we need a specific tool, that person can go to the storeroom and get that tool while I can continue to work. So that person's really important. The third person you'll meet in the room is what's called a scrub technician or a surgical assistant, various terms. But basically it's a trained person who helps the surgeon manage and manipulate the tools of our trade, the instruments. So they are not operating on you, but they are handing me tools, suture, and other materials so I can do my job. And there's kind of a dance between the scrub tech and the surgeon. We get a good thing going when we know one another about what we need, how we ask for things, and whatnot. You've probably seen in the movies, the surgeon sticks their hand out and something gets slapped into their hand, some instrument. That's the scrub tech. Some scrub techs, old school, do the slapping. Most these days don't. But that's an important part of the team because I can't pick from a table of tools efficiently the exact tool that I need. They're handing it to me and I'm giving it back to them. The fourth person in the room, so let me see, anesthesia, CRNA, circulator, so fifth person in the room, scrub tech is the first assistant. The first assistant is another person who's helping me do my job. So I'm the surgeon. I'm the last person in the room besides the patient. But the first assistant is essentially helping me do my job. They usually do things like pull tissue out of the way so I can see down in the wound. They'll use a suction device to evacuate any blood or fluid that may be in the wound so I can see what I'm doing. They may hold certain instruments for me so that they're essentially acting like a third and fourth hand for me. They're really important as well. Many times they will also be participating in helping to close the wound, sewing the wound up, putting dressings on, and that type of thing. So that's an important thing for me to have on hand because I only have two hands, and sometimes you need four. So the first assistant is really my right-hand man or woman directly dealing with the patient. Some cases you actually have a second assistant, which is another person that's doing that job. Joint replacement surgeons often will have two assistants rather than just one. Most spine surgeries just need one assistant, but sometimes joint replacement doctors need two, and the reason being is they have to hold the leg or hold the arm in a certain position, and then you need even more than 4 hands. You need 6 hands. The last person in the room, other than you and me, the surgeon and the patient, patient and the surgeon, is there may be one or more representatives of implant companies. In orthopedics, particularly in spine, we use a lot of hardware, so screws and rods and things like that. And these folks are the representatives of the company of the materials that we're using. So they help the team gather the right piece of equipment. They help the team get the right screws or rods. They make sure that in the background that the storeroom is stocked with materials. They do not operate on you. They do not touch you. They do not scrub their hands. So they are part of the team in the room, but rest assured the implant representatives are not operating on you. There have been cases where rogue surgeons have had implant reps scrub their hands. That's really inappropriate. It doesn't happen very often. I haven't heard of it happening in a very long time. That's just not appropriate. But we rely on those people to represent their products. In the spine world, there are possibly 2 other people in the room. One is a person who is operating a device that is helping us suck the blood out of your wound and reprocessing that blood so we can give it back to you. The machine is generically called the Cell Saver. And in people's surgeries, big operations who may lose a lot of blood, we want to give people back as much blood as we can so we can avoid a blood transfusion. It's your blood. You can't react to that. And it uses a special machine that filters the blood, cleans the blood, and allows us to give it back to you. So there may be a representative there, and you probably won't ever see this person in the room operating that machine. The last piece of the spine puzzle, in some cases, not all, but some, is a technologist who is operating the intraoperative spinal monitoring system. That's a big, long phrase, but basically it's an electronic device that attaches to your body and allows us to monitor how your spinal cord is working. So we're trying to minimize the chance of injuring or damaging your spinal cord. And some surgeons, not all, but some surgeons will use this technology to give them one extra piece of information about you to try to minimize the chance that we're going to hurt you, okay? So that's the team in the operating room. So we're not going to go into surgeries themselves because they're all different, but needless to say, when the patient comes into the room, the anesthesia team will put a mask over your face, which is just oxygen. They'll inject some medicine into your IV and you fall asleep and you won't remember anything essentially from that point forward until you wake up again. They put some other medicine in there to keep you asleep. They'll generally put a tube into your mouth, down your throat, into your lungs to keep the airway open so they can control the airway, the breathing tube, and make sure that you can stay asleep. And then they use a combination of intravenous IV medicine and gas that you breathe in and out to keep you asleep, keep you comfortable, keep you relaxed. We position you on the table depending on which surgery you're having. It depends on if you're face up, face down, on your side. Do the surgery, put the dressing on, and then the anesthesia team then reverses the medicines they've given you, removes the tube, and then we wheel you out and go back to either what's called the post-anesthesia recovery care unit, PACU, or it used to be called the recovery room, or sometimes in some facilities you'll actually go back to your previous room. And that's where you'll wake up. Basically, your body will get rid of the medicines that we gave you. We'll make sure you're comfortable, and then we start your post-operative recovery. In the post-operative care unit, the PACU, a post-anesthesia care unit, or the recovery room, you will be cared for by a nurse who's a specialized critical care nurse who knows how to manage someone who's recovering from anesthesia. The anesthesiologists also oversee the recovery room services as well. So that's basically it. That's kind of the long and short of what happens in your operating room surgery day. We'll talk later about specifics of different operations and whatnot. We've done a little bit about that in the past. But I hope this gives you a little bit of an idea of kind of who you see, what's going to happen, what's around you. There is a huge team of people who are there to support you, the patient, in getting through, getting past, and getting over your surgery so you can get better. We're not even talking about the team of people that the housekeepers, the cooks, the technicians that transport people back and forth. I mean, it's a huge operation, a lot more than you would really believe. So I just wanted you to know that we're all here for you. The patient, the person getting surgery, is our primary focus. We do everything possible to make it a good experience, make it a safe experience, make it a successful experience. We do ask the patients follow some rules and requests like we talked about before. Those are, again, really to help expedite the process and to keep it safe. So anyway, that's it for today. I think that today's kind of a sad day because my favorite liaison, Brooke, is retiring from TOA and moving on. We wish her all the best of luck. But Brooke has been she's the face behind the scene here. We've got lots of people here, but she's one of the people that's really gotten this thing started, and I really appreciate her input there, and I wish her well. It's sad to see her go. If you have questions, please comment on the Facebook page. If you would like to email me directly, my email is stahlmangc, stahlmangc @toa.com. You can go to our website, www.toa.com, to learn more about Tennessee Orthopedic Alliance, our physicians, our services, and what we can offer you. I think next week, which is Valentine's Day, we don't have anything on the schedule, but I think we're going to try to impromptu something. So if you're interested, what I'd like to try to do is have you guys, sorry, I'm from California. You guys means y'all. Have y'all send in questions that we can answer. Now, that doesn't have to be just spine. It could be pretty much anything about orthopedics. If I can answer it intelligently, I will. If not, I'll get the information from somebody who can. But it might be a good idea for every few episodes or every 6 episodes, something like that, to kind of have a question and answer, a Q&A type of thing, so that you can be involved in shaping how this whole Facebook thing evolves, okay? So please think about that. Get online. Let us hear your questions, your comments, and let's see if we can have some fun with it next week. Same time, noon, Friday, the 14th of February. Other than that, again, I'm excited. Coming up fairly soon, we're going to start having some guests here to talk about other subjects. I hope that goes well, and I hope that's interesting to you. So look on our Facebook page for that type of information. And until then, stay warm. It's still snowing outside. Go out there and have your best life. Have a good life, but have your best life.